So in this first section regarding gastroenterology and regarding the topic esophageal tumors, we'd be studying about different types of carcinomas, the aggressive carcinomas related to the esophagus. So in this first section, we'll be studying about different genetic factors that are involved in creating an esophageal carcinoma, what are the genetic factors that makes a cancer very malignant. And then the second topic will be the clinical features regarding esophageal carcinoma, the malignant esophageal cancer. And then what are the different types of ways to diagnose this aggressive esophageal cancer? And then what are the different treatment modalities that we can offer to this cancerous patient? So the esophageal squamous cell carcinoma is the first, which is the most common cell cancer regarding esophagus. It consists of almost 90% of all cancers in Asia, Africa, and East Europe. It's more common in the eastern side than the western side, but once, a very long time ago, this esophageal squamous cell carcinoma was more common in the west as compared to the east, but then its incidence started decreasing in the western population. It is more common in patients older than 60 years old. So now if we talk about the risk factors regarding esophageal squamous cell carcinoma, the first and the foremost important risk factor is the tobacco use. Almost 90% of patients with esophageal cell carcinoma are smokers. And then the second most important risk factor is the alcohol use. 70% of these patients are the patients that use alcohol. Vitamin A, C, and E deficiency. This esophageal squamous cell carcinoma is more common in lower socioeconomic status people. For example, in poor people where they don't get many supplements and they have different types of deficiencies such as vitamin A, C, and E deficiency. As vitamin A, C, and E have a very antioxidant properties, such as that it inhibits the release of free radicals and nitrosamines that are potential risk factors for any sort of cancer. The second most important risk factor is the deficiency regarding folic acid, zinc, and selenium. These are also the factors that causes an increased production of free radicals and nitrosamines. So the deficiency of these deficiency of folic acid, zinc, and selenium causes cancer in most patients. Hot drinks. Hot drinks can cause a very potential chronic thermal injury to the mucosa of the esophagus and thus cause chronic inflammation and can be a potential risk for squamous cell carcinoma. For example, herbal tea in South America is very used commonly, and it is a risk for squamous cell carcinoma. Other than that, there are different types of esophageal disorders, such as achalasia, Plummer-Vinson syndrome, because it causes the stasis of food material within the esophagus and then can cause chronic inflammation and causes squamous cell carcinoma. The other risk factor is called as tylosis. Tylosis is an autosomal dominant disease which has the hyperkeratosis of palm, soles, and some of the other skin types. It is most common in females, and the gene that is mostly involved uh, following the risk of a squamous cell carcinoma is the TOC gene, which is the tylosis esophageal carcinoma gene. It has a potential for producing a squamous cell carcinoma too. Other than that, patients who are very much obese and have a very high BMI have risk to produce a squamous cell carcinoma. Other than that, the use of aspirin and other sort of NSAIDs can also cause squamous cell carcinoma. So these are the different types of risk factors that can cause squamous cell carcinoma. Now, if we talk about esophageal adenocarcinoma, like I was saying that The esophageal squamous cell carcinoma is more common in the east, but the esophageal adenocarcinoma is more common in the west. And it is the second most common form of esophageal carcinomas. It is more common in the Western countries, and it is twice as much frequent in men as compared to females. And it is common in high socioeconomic status as compared to squamous cell carcinoma, which is more common in lower socioeconomic status people. And it is usually present in the lower third of the esophagus. Esophagus is usually divided into three parts, which is the first one third, the second one third, and the last one third of the esophagus. So esophageal adenocarcinoma is usually more present in the distal lower third of the esophagus. Very interestingly, the HB infection, Helicobacter pylori infection, and NSAIDs usually have a very protective role in defending the esophagus from producing an esophageal adenocarcinoma. So the risk factors of esophageal adenocarcinoma are tobacco use. If a person stops using tobacco and stops smoking, there's a very much reduced risk of esophageal adenocarcinoma to be produced in this individual. Other than that, more common liquor use other than alcohol is a potential risk factor for adenocarcinoma. GERD, that is the gastroesophageal reflux disease, has a very crucial effect on the mucosal surface of the esophagus, and thus it can cause the surface and the mucosal surface and the epithelium of the esophagus to regenerate into more cancerous form. Other than that, a very strong association of adenocarcinoma is the Barrett's esophagus. Barrett's esophagus is when the metaplasia occurs and the one epithelium surface of the esophagus is changed into a different type of epithelium surface. And lastly, obesity, which is also a risk factor for esophageal squamous cell carcinoma, causes esophageal adenocarcinoma to any person with high BMI is at a risk of producing an esophageal adenocarcinoma. So if we talk about the genetic factors, there are multiple epigenetic and genetic factors that can cause carcinoma and malignancy in an individual. The different types of molecular factors that are usually involved in producing the malignancy stepwisely. So if we talk about these molecular factors, the first is the self-sufficiency in the growth signals. These cancer cells, the human cancer cells, are more easy to produce their own growth signals, and they are also capable of altering the growth signals within the body, and they can also cause these altering in the growth signals, which can cause them to proliferate even more other than the normal cells. Other than that, insensitivity to the anti-growth signals, they can cause a reduction in the anti-growth signals, such as the anti-tumor suppressor genes, such as P53. They can cause these P53 genes to be completely demolished, and thus they can grow infinitely. Avoidance of apoptosis. Apoptosis causes a break in the proliferation or in the growth of a cell pool. So the genetic factor involved in this is that these sort of cancer cells can also cause apoptosis to be completely slowed down, and thus they can proliferate at a very high rate. Uncontrolled replicative potential. These malignant cells, they have a potential that they can proliferate very uncontrollably, And the other genetic factor is the sustained angiogenesis. Angiogenesis factors such as vascular endothelial growth factor and these other factors, they produce blood vessels within these human cancerous cells, and thus uh, they can get all their supply from these blood vessels and they can grow even more. Lastly, the invasion and metastasis. They cause abnormalities within the cell adhesion molecules such as cadherin and caterin, and thus these cancer cells can invade the other tumor, the other normal cells, and they can cause metastasis, and they can migrate to different parts of the body and to different lymph nodes and cause metastasis. So if we talk about a cancerous patient, how is the cancerous patient going to be presenting? The early stages of cancer, usually the patients are very asymptomatic and we have no clue that the patient actually has a cancer. So in these clinical features are usually present in patients who are in the advanced stage of esophageal cancer. Clinical features such as dysphagia to solids to liquids. These patients usually have painful swallowing, which starts with solids first, and then slowly it gets worse, and it increases to the difficulty in swallowing with liquids. The second clinical feature is the patient might present with weight loss, odynophagia, which is painful swallowing, chest pain. The patient might present with slight chest pain or epigastric discomfort. Iron deficiency anemia. A patient might come to the hospital and have some laboratory findings, which might be anemia, which is without any trace. So a cancerous patient might also present with anemia, which is most commonly the iron deficiency anemia and the anemia of chronic disease. Cervical lymphadenopathy, if the patient is at a stage when the cancer has been migrated and metastasized to the regional lymph nodes, then a patient might present with the cervical inflammation of the lymph nodes, which is called the cervical lymphadenopathy. Hoarseness, the patient might present with a hoarse voice. And lastly, esophageal aortic fistula, which is a very deadly complication which involves the heart. So there are different types of diagnosis, there are different types of techniques to diagnose an esophageal carcinoma, but the most common way to diagnose an esophageal carcinoma is by the endoscopic biopsies. Endoscopic biopsies is with the help of an endoscope which is passed through the esophagus, and while visualizing the esophagus, and if we see any part of the esophagus that is that has an abnormal epithelium, an abnormal mucosa, we would take a biopsy with the help of the endoscope. Chest x-ray. With the help of chest x-ray, we could see different types of abnormalities such as pleural effusion, or we could see an air fluid level or a dilated esophagus with an air fluid level. And we could also see aspiration pneumonia, that is one of the complications of esophageal cancer. Barium contrast esophagography. Barium contrast esophagography, we could visualize that the patient is suffering from an uneven or an defective part of the mucosal surface when the patient swallows this barium. Fluorescence in situ hybridization, which is also called as FISH. This image over here is an image of a fluorescence in situ hybridization. As you can see, these other blue cells are the normal cells, whereas the dotted red and green lines are the abnormal parts. Conventional chromoendoscopy and electronic and chromoendoscopy. Chromoendoscopy is a technique in which we use different types of stains to diagnose the mucosal surface and the epithelial surface of the esophagus, and which can direct us to take different types of biopsies. The different types of stains that can be used for chromendoscopy is the Ludell's iodine solution, such as uh, chromophene, such as methylene blue. These are different types of stains that are helpful in chromendoscopy. This image over here is of esophagus, and this stain is used for the chromendoscopy, and thus we can visualize the areas within the esophagus, the epithelium and the mucosal surface within the esophagus that can help us to take biopsies. Autofluorescence imaging is the use of different type of radiations and different type of blue and violet lights that help us in taking the image of the esophagus. And lastly, the confocal laser endomicroscopy is an in vivo microscopic imaging technique of the esophagus. So these are the different techniques that are usually used in diagnosing an esophageal cancer. So if we talk about staging, staging is a very important part in treating a patient with esophageal carcinoma. For example, primary tumor T. We start with primary tumor T, which tells us about the invasion of the tumor within the esophagus. If we start with Tx, it is the tumor that cannot be assessed, that a patient might not be suffering from esophagus and we cannot assess the invasion of the tumor. T naught is that no evidence of primary tumor, it's almost the same as Tx. TIS is tumor in situ, which is the high-grade dysplasia. There's a high-grade dysplasia that occurs within the mucosal surface of the epithelium. T1 is then further divided into T1A and B. T1A is the tumor invades the lamina propria and the muscularis mucosa, whereas T1B is that the tumor has invaded the submucosa. T1 IS in situ and T1A, B, and T1-2. These are the stage. If the patient presents with staging of T1 and T2, these patients can be resected with the help of surgery. The tumor can be resected completely. T2 is the invasion of the muscularis propria. T3 is the invasion of adventitia. And T4 is when tumor invades the adjacent structures. Adjacent structure is divided into two parts. T4A is the resectable tumor, including the pleura, pericardium, or the diaphragm. And T4B is the unresectable tumor. This tumor cannot be resected with the help of surgery, and it is invading the other more prone to death structures, more important structures such as the heart or the lungs. So if we talk about the regional lymph nodes, this is when the tumor has reached the lymph nodes and has almost metastasized to the lymph nodes. NX is the regional lymph nodes that cannot be assessed, and NOT is no regional lymph nodes that has been metastasized. N1 is that metastasis is present in almost 1 to 2 of the regional lymph nodes. N2 is the metastasis of 3 to 6 regional lymph nodes, and N3 is metastasis of 7 or more of the regional lymph nodes, which is almost the most advanced stage of the esophageal cancer. So distant metastasis, which includes M. MX is the distal metastasis that cannot be assessed. M0 is that no distant metastasis has occurred, whereas M1 is that distant metastasis has finally occurred. Other than that, the histological grade, which is not usually used for staging of the different types of cancers, but GX is that grade cannot be assessed. G1 is that the grade is well differentiated. Grade 2 is that it is moderately differentiated. Grade 3 poorly differentiated. And grade 4 is that the metastasis and the tumor is completely undifferentiated. So staging is the most important part of diagnosing and treating an esophageal cancer or any type of different cancers, so that we can treat the patient on the basis of the staging and decide whether the patient needs surgery or needs chemotherapy or radiotherapy. So finally, if we talk about the treatment of esophageal cancer, treatment includes the having the advice from different types of expertise, such as the gastroenterologist, the surgical, the radiation, the medical oncologist, and expertise from the palliative care. So the treatment have three different types of general principles. The first principle is that the surgery standard treatment for localized or non-superficial tumors, surgery is mostly important. For a patient with a localized tumor who is not a surgical candidate, chemoradiation is a very good option with curative intent, which can be considered. Other than that, metastatic disease, palliation is the foremost option that is available for these type of cancerous patients. So if we talk about surgery, like I've said before, is usually in patients with T1A or B and T2 staged patients of esophageal carcinoma. The surgery that is usually involved for esophageal cancerous patients is esophagectomy, in which the part of the esophagus which is diagnosed with the tumor is completely resected, and the rest of the healthy esophagus is then combined with the stomach. So there are two different types of esophagectomy that can be given as options to the patient with esophageal cancer. The first is the transthoracic cancer esophagectomy. This esophagectomy has a very better visualization of the whole of the esophagus, and it consists of a complete resection of the cancerous part of the esophagus. And other than that, accurate staging, it causes a surgeon or the oncologist to have a very accurate staging of the esophageal cancer. And lastly, it has very improved long-term survival of the cancerous patient. The second type of esophagectomy that can be offered to patients is the transhiatal esophagectomy. It has a very short operative time, and it has a lower post-operative morbidity as compared to transthoracic, which has a very higher post-operative morbidity and mortality. This is a very newly emerging technique that is used as a surgery for patients with esophageal carcinoma, which is a minimal invasive surgery. It has a very less post-operative pain, and it has a short hospital stay. It has low need for blood transfusion or no need at all, and it has a very lower cost. It's very cost-effective. This is a new technique that is slowly emerging in different parts of the world. So if we talk about the endoscopic treatment, there are two types of endoscopic therapy that can be offered to the patients. One is with the curative intent, and the other is with the more palliative intent. In the curative intent, we have two subtypes. One is the resection, which is the complete resection of the esophageal carcinoma with the help of an endoscope. It consists of endoscopic mucosal resection. The second is that the esophageal submucosal dissection, and the second most important part of the curative treatment is the ablation. It is not a resection. It does not cut out the tumor completely, but it ablates the defective or the abnormal part of the esophagus. It includes photodynamic therapy, And then it includes radio frequency ablations. This ablation is with the help of different types of radiations. And then lastly, the technique is the cryotherapy with the help of resection. So these photodynamic therapy, radiofrequency ablation, and cryotherapy, they can be used alone. These ablative techniques can be used alone, or they can be used with the help of resection, such as endomucosal resection or esophageal submucosal dissection. So this is a picture of endoscopic mucosal resection. The first is the most simplest method, in which a polypectomy snare is being used and the defective part of the mucosa is being cut off with the help of a snare. The second is the cut method, in which cut and pull method, in which this mucosal part of the defective mucosal part of the esophagus is first being pulled, and then it is cut with the help of a polypectomy snare. The third type is called as the cap and cut method. In this, a transparent cap such as this is wrapped around the abnormal mucosa, and it is being sucked with the help of this cap, and with that a snare is being also involved, which helps in cutting down or resecting the mucosal part. And lastly, the ligate and cut method, in which this part is being the part with the abnormality is being ligated first, and then it is cut with the help of a polypectomy snare. So lastly, the endoscopic treatment, which includes palliative intent. The most useful method and the most common method that is used around is stenting. Stenting is for patients who have very severe discomfort while swallowing, which is dysphagia or odynophagia, and to give these patients a treatment option which is for a very limited time. The treatment of choice for relieving dysphagia, like I've mentioned, and restoring the lumen patency. For example, the esophagus that has the part of the esophagus that is cancerous, it completely abrates the lumen of the esophagus. So the stenting is a method to restore the patency of the lumen, and thus the food can pass through the esophagus. It is usually preferred over simple dilation of the esophagus. And metallic stents are also used, and plastic stents are also used, but metallic stents are usually preferred than the plastic stents. So this picture is of a patient with esophageal adenocarcinoma. And this is post chemo radiotherapy. This patient also has come up with an esophageal aortic fistula, which is a complication. So this next picture is the use of the stent for this type of patient after the chemo and radiotherapy. So the other treatment modality that can be offered to patients with more advanced stage of esophageal carcinoma is the chemotherapy and the radiotherapy. Neoadjuvant chemotherapy is usually the most common type of therapy that is offered to patients with esophageal cancer. The different types of chemotherapy the different types of chemotherapy that are used is the cisplatin or the 5-fluorouracil can also be used in this chemotherapy. Neoadjuvant chemoradiotherapy is the use of an addition radiation therapy, which is also very useful for cancerous patients. Other than that, neoadjuvant radiotherapy is to be studied more about, and adjuvant chemoradiotherapy is not in the market still, but more studies are being going on for this type of chemoradiotherapy. Lastly, we'll be studying about the prognosis. The 10-year survival rate of a patient with squamous cell carcinoma and adenocarcinoma. So if you see in this graph, one side is the 10 years that has been given and the risk adjusted survival. So if you talk about squamous cell carcinoma with stage 1A, so this patient has a very high rate of survival, which is around 100% first within the first 2 years, and then uh, to gradually decreasing to almost 70% within the 10 years. So this patient 1A, 1B, and 2A, these patients can be given the option of surgery that can completely resect their cancer from the esophageal mucosa, and they can have a very high rate of survival for within the next 10 years. Other than that, if we talk about grade 3 ABC, you can see that in this graph, it is clearly proven that the risk of survival, the percentage of risk of survival is decreases very drastically within the first 2 years of the patient's diagnosis of the cancer. And the rate of 10-year survival is less than 20%, unfortunately. The same case with adenocarcinoma. The grade 1A patient have a 10-year survival rate of almost 75 to 80%, and other than that, the patients with stage 3A, B, and C have a very drastic fall within 1-2 years of their survival rate, and is almost around 18 to 19% survival rate for the next 10 years. This is all from the first section of esophageal carcinoma. Thank you for watching sqadia.com.